Shashank, is that you? Good morning, everybody. Welcome. We would start in another 3 to 5 minutes.
Yeah, good morning, Shashank.
I think we'll just wait for another 2 minutes. 11:05 will start.
Yeah.
In the meantime, can you just check your PPT once, madam?
Should I share it now only?
Yeah, just for checking purposes right now. We'll wait for another 2 minutes and we should start then. Yeah, perfect.
Can you see?
Yes, absolutely. I think we'll keep it at this. Make it, maybe you can make it full screen. We'll keep it at this and then I'll introduce him.
Make it full screen.
Yeah.
Okay, it's not becoming full screen. Shall I close it and then do it once again?
Okay, no problem. Good morning, everybody. Welcome to this session of Maharashtra Rheumatology Association PG sessions. We do have a senior rheumatologist with us today, Dr. Mamatha Venkatesh. She's a senior rheumatologist attached to Bombay Hospital. We have been looking at ankylosing spondylitis and seronegative spondyloarthritis group in the last few sessions. And today we would be looking at the treatment aspects of ankylosing spondylitis and the entire spondyloarthritis as a whole, but mainly ankylosing spondylitis. I would like to welcome and request Dr. Mamatha Venkatesh to take over. Over to you, madam. Are you able to share?
Can you see my screen?
Started screen sharing. Yeah, perfect. Only thing, if you can make it full screen.
Your voice is very low.
Yeah, if you can make it full screen. Otherwise, we can see the screen.
I'll just give me a moment. Okay.
Yeah.
If you can tell me how to make it full screen, I'm just not able to do it. Stop video.
No. Don't go to stop video. Just in the PowerPoint, go to right bottom. You can see a blackboard like.
Yeah.
Just click on that, it will become full screen.
PowerPoint
Below
down
that,
part
below
is
that.
not
Take it,
adjustable.
take the cursor down. Right hand corner, below that.
No, I can't see the PowerPoint. I'll just leave it there.
I think
Oh
you
God, I lost the entire thing.
should I share it from my end? I'll share it from my end.
No, wait.
Hmm?
No,
Okay.
Shashank, if you want to
Okay,
share,
okay.
1 second, hold on. I'll just log
Yeah,
out and get back. Okay?
Otherwise, I'll share from my end, madam. You just keep telling
No,
me.
I'll send you one just now.
Okay.
Shashank, you're sharing or should I share?
Yes. Just give me a moment. I'll share. Just
Yeah.
just downloaded your PPT again. Just a moment. Yeah, madam, go ahead.
Thank you. Can I start?
Yeah, please go ahead, please.
So, am I audible clear?
Yes, absolutely, madam. Go ahead.
So I will have to change or you will change now?
I'll change. You just keep telling me. I'll change from my end.
Yeah. So, I will briefly touch on physical examination. Good morning, everybody. And I hope this will be a useful session for all of you. Initially, I'll just touch upon a little physical examination. That was what I was asked to do. And then the EULAR recommendations and non-farm, and then we'll elaborate on each of them. And the care to be taken and disease monitoring tools and treatment in special cases. Next. Okay, so next one. So examination, it is peripheral or axial, and peripheral usually it is what we do for any joint examination. Look for synovitis at joints, at all peripheral joints, and also for skin, any psoriatic patches. And then at the same time, we also would look for any dactylitis or enthesitis at the tendon insertions. So these are the things in peripheral arthritis. This is what we would be seeing. Next slide, please. So axial, yeah, next slide. Yeah. In the axial, we would be looking at more the shoulder joints, then the hip joint and the spine. essentially. And basically, we'll be looking at the range of movement of every joint. When you're experienced, definitely you will be able to do it off fast and wouldn't take much time. Though here it might look like who's going to sit and measure, 5 centimeters, 2 centimeters, 1 centimeter. But once you're a little experienced with it, you'll be able to do it faster. So please go ahead. So this is a basic flesh test, occiput to wall distance. Normally, for any of us, if we stand to a wall with our hips everywhere when we are examining the patient, the glutes should be to the wall, hips should be to the wall, and the shoulder also should be to the wall, with the knees and ankles also to the wall. And normally we can anybody can touch the occiput to the wall, but in cases of ankylosing spondylosis, where there is already some amount of delay in therapy, or there is a progression of disease, then there is a likelihood that there is a possibility that this distance is increased, and this can be because of the deformities and the degeneration which happens at the joints, cervical joints, or it can also be because of active inflammation and pain and tenderness. These also can restrict the movement. So in such cases, in cases where the inflammation is active and all active, any intervention, suitable intervention, can help to reverse this to back to normal, that is 0 degrees. Next slide, please. So this is another tragus to wall. Also, similarly, everything, either it is delayed interventions and already joint destruction has happened, or joint is more immobilized, or it is only immobilized because of inflammation, which can be tackled and can be reversed. Next one. So this is mostly for surgical approach. You can go ahead, please. And this is for respiratory, for the spine at the thoracic region, and also at the cervical, lower cervical region. We can look for the lung expansion on deep inspiration and expiration. Normally, this changes even because of age also. So anything below 2.5 to 3 centimeters should be considered as decreased spinal mobility at the rib cage. Costochondral junction is affected, or even the spine is affected, and the mobility of the chest is hampered. So most people generally have above 4 to 6 also, 6 or 7 also, but anything which is reduced below 2.5 is definitely restricted movement. Next one, please. So these are all tests for the hip movement and the SI joint movement. Patrick of Faber's test, flexion, abduction, external rotation, all for the SI joints and the hip movement. Next. And this is for lateral spinal flexion, for the spinal movement. So here again, you have you make the patient stand to the wall and let the patient first take the, I don't know if I can, can you see my cursor? No. Okay. So the first picture shows one has to measure from the tip of the finger to the floor, the distance. Normal is more than 10 centimeters generally, but when it is restricted, as in ankylosing spondylosis, in that case, it is much lesser than 10 centimeters. It can actually be up to 18 centimeters, 19 centimeters also in good mobility. But when it is restricted, it is below 10 centimeters, and it implies that the spinal joints and hip joints and SI joints are affected. Essentially, it is for the spinal joints. Next picture, please. So this is a modified Schober's test. Here, the posterior superior iliac spine central point between the two posterior right and left posterior celiac posterior iliac spine is taken, and the midpoint from there below that 5 centimeters and above that 10 centimeters is marked, and on full flexion with or as much flexion permissible, uh, 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 with knee straight, and try to make the patient touch the toes or the floor, and or as much as flexion is possible. We check this distance, and any distance less than 4 to 5 centimeters is considered as restricted uh, movement. And this is an important test also, which can easily be done in the clinic. Next one. So now we come to the Euler recommendations for treatment of ankylosing spondylosis. Uh, so we have non-pharmacological aspects and pharmacological aspects. And can we go to the next one? So the principles have been made essentially for us. These are called overarching principles uh, for uh, for making the recommendations. And this is basically to understand that it is a potentially severe disease where you can see people, patients would be bedridden also. And there are even youngsters who cannot look up at all and are totally arched, and they cannot look forward or straight. So therefore, we need to understand that it is a severe, it can be a severe and debilitating disease. And essentially, the quality of life is also extremely affected. And patients are sometimes bedridden or chair-bound. And there are actually bedridden patients also, youngsters also, because of the severity of the disease. So we need to keep this in mind. And so our aim should be to control the symptoms and inflammation. When we control inflammation most often, and if we control inflammation early, which is possible today, symptoms are also controlled, and progression of structural damage is stalled. And hence preservation and normalization of function if possible, and social ostracization and all that is prevented, and people start actively participating in social activities. So that is these are two important things. And treatment, as I told you, can be non-pharmacological or pharmacological. And non-pharmacological aspect is a very essential part, which we'll talk about. And there is no need to keep the patient in dark about what sort of the first visit, at least we first or second visit after with all the reports, we would have to spend some time with the patient and explain to the patient the prognosis, the path which the disease is likely to take, and uh, the amount of monetary strain it might cause to the patient if it is not well controlled with simpler drugs. So in that case, we may also have to tell the patient on how to plan finances uh, and keep it ready for necessity. So and the patient should all along be with us, and we are definitely that can avert a lot of medical legal conditions also, situations also. So, and the therapy is not a blanket therapy for everybody. It has to be the therapy is not a blanket therapy for everybody. It has to be uh, tailor-made for each one. So it is broadly similar, but each one acts. Each drug differs in the way it behaves with each patient. So even the way patient responds also is different. So therefore, it is necessary to tailor-make the therapies. Next slide, please. Like I told you, the treatment recommendations. This is a there are 15 recommendations. We'll just run through them. The treatment has to be individualized. It also depends on axial, peripheral, and extramusculoskeletal manifestations, and also whether it is radiographic progression is there or non-radiographic progression, ankylosing spondylitis. We have to check all that. Then
First, now you take SGO
disease monitoring of patients with
is about 19.
Shashank, can we request everyone to mute themselves?
Sorry to interfere. Shumaila, Dr. Shumaila Ansari, can you please mute yourself? Dr. Shumaila. Dr. Ansari, please mute yourself.
So, okay. The recommendations further also say that mostly initially we start off with a. Can you just go to the previous slide, Shashank? Right, previous slide. Yeah. So a treatment should be guided according to predefined treatment target. Target we've already seen is to make the patient socially active and decrease the progression of disease. And to the next slide, please. The fifth one says, fifth recommendation clearly indicates it is the NSAIDs which are important and are the first line of management. And next slide, please. And after that, anything else comes. Initially, it is non-pharmacological, then it is NSAIDs, and then you can think of even local corticoid, glucocorticoid injections at local sites. If it is a single joint or a 1 or 2 joints, you can always try and give a local glucocorticoid injections. We need not. We should remember not to go overboard and keep giving at every site glucocorticoids. It does not do any good for the patient. And then the axial, normally the conventional DMARDs, that is methotrexate, sulfasalazine, and all these are not advised for ankylosing spondylosis axial disease. But there is a study also, and there are reports also where sulfasalazine and methotrexate given together for axial disease has helped, especially, but definitely it is not the preferred drug. This is not the preferred combination of drugs, because it is only given where cost is a issue. But otherwise, once NSAIDs and non-pharmacological treatments don't work, then we go on to biological drugs. And in fact, if we are really convinced about our diagnosis and the patient is young and efforting, today we would prefer to go straight for an biological if the disease is very active, severely active. Then other uveitis or IBD, all these we would prefer to give TNF blockers, and psoriatic disease is mostly treated with IL-17 inhibitors. Next slide, please. So, in case of an absence of response to any of the drugs, either NSAIDs or at the level of NSAID, if there is no improvement, relook at your diagnosis. It could be an infection, it could be anything else also, injury, fracture, anything. So it is better to relook and reevaluate the patient's diagnosis. So, and also, in case of failure of any biological DMARD, you would try another. It is advised to recommended to try another biological agent or even a JAK inhibitor. In fact, sometimes because of cost effectiveness, we choose JAK inhibitor straight off rather than the other TNF blockers or IL-17 blockers. Then if the patient has already come at a stage where they're bedridden because of deformities, because of ankylosis, then an hip arthroplasty would be helpful, and maybe osteotomies also will be helpful. But our aim today should be to not let the patient to go to that stage as to have a surgical intervention. Next slide, please. So this is the same. This is a slide depicting all the a flow chart of how to go about of what we explained just now. Pharmacological, non-pharmacological intervention, then pharmacological, first NSAIDs, and then if they don't work, then biologicals. And biologicals, TNF inhibitors, IL-17 inhibitors, and JAK inhibitors. Next slide, please. So, non-pharmacological, essentially, it is one has to encourage the patient to stay active, and this also reduces pain, especially when there is too much of pain. Nobody would ask them to go for exercise or anything. Take a proper NSAID, and with NSAID, when it improves, we should encourage them to stay active, and it also reduces fatigue and improves posture. And aerobic exercises and muscle strength building exercises. Aerobic exercises, as we all know, it improves, boosts the mood also. And HLA-B27 patients, positive patients, generally I have a tendency to be a little more remorseful, and with a lot of negative thoughts. So exercise helps. Then strength building exercises, muscle strength building exercises, stretching are also essential, and but they must be encouraged and in fact instructed to quit smoking. And supplements like calcium and vitamin D, because of the nature of the disease itself, bone mineralization reduces, as well as demineralization also increases. So therefore, exercise and supplementation with vitamin D and calcium is essential. Then they should also join a support group to help them cope with the stress of having angst. Next slide, please. So limit alcohol, caffeine, and maintain a good weight. These are essential even for general bone health, and to prevent restricting ankylosis. Next. So when we come to beyond NSAIDs, when we come to after non-pharmacological, we start off with NSAIDs, Celecox, any COX-2 inhibitors, or even generalized, even non-specific inhibitors, COX inhibitors, diclofenac, ibuprofen, indomethacin. They all can be given, and the other drugs available are biologic drugs, TNF inhibitors, and IL-17 blockers. And like I told you, methotrexate and sulfasalazine can be also tried, where finance is a issue. And corticosteroids, intramuscular, intraarticular injectables, if it is 1 or 2 joints, and occasionally can be given, not repeatedly into the same joint. Next slide, please. The NSAIDs, next slide. NSAIDs can be given, these reduce inflammation, obviously, and I mean, as non-steroidal, as the name indicates, and they should be given in the maximum permissible doses of NSAIDs for a considerable amount of period. And but if they are not helping in reducing the inflammation, we need to think beyond NSAIDs. And should not wait till there is a renal damage, kidney damage. Next. Maybe maximum 15 to 20 days or 1 month also. Beyond that, we should start thinking about disease modifying agents or immunosuppression. Next slide. Before we think of any, at every step, we we have to think about the correctness of our diagnosis and look for other comorbidities which are causing, like even diabetes or any other severe osteoporosis, which is called all these which can prolong the pain, prolong recovery, and also we have to think of infections also, like I have told you earlier. Tuberculosis, brucellosis, or any fractures or any atypical infections also should be thought of. Can we go to the next? Or malignancies also in some. Immunosuppression should be considered in patients with persistently high disease activity despite conventional treatment. Next. So elevated CRP is one of the strongest predictor of good response, which might happen. I mean, for therapy with biologics, and also MRI SI joint is the second best predictor of response with to TNF inhibitors. So CRP and MRI SI joints, if both of them are showing active disease, indicate active disease, then comfortably and there is a good prognosis for TNF blockers to act. Next slide, please. So sulfasalazine, methotrexate, TNF inhibitors, IL-17 and JAK inhibitors, which I have already mentioned. Next slide, please. Next slide. So infliximab is a chimeric monoclonal antibody. The others, adalimumab, certolizumab, golimumab, these are all human monoclonal, completely human monoclonal antibodies. Etanercept is a receptor blocker, TNF receptor blocker. Next slide. So the dosage is 5 milligrams per kg weight. Etanercept is 25 milligrams twice a week or 50 milligrams once a week. Golimumab is 50 milligrams subcutaneous. Adalimumab is 40 2 weekly. This is initiation phase, and when in continuation phase, depending on how well the patient is responding, they can be further spaced out. Say to 2 weekly or 1 monthly or 2 monthly, depending on how the response is. Next slide, please. JAK inhibitors, over 5 years, one has to be a little careful with JAK inhibitors, though they're good and cheaper option for angstbond. Over 5 years, there is a higher risk of adverse cardiovascular events and malignancies also. There's an increased tendency for malignancies, risk of malignancies. So one has to be careful with tofacitinib. Then also, like I said, cardiovascular events are increased, risk is increased after 5 years, even during initiation, and every 3 monthly or 6 monthly, we have to keep a tab on their lipid profiles and assess their cardiovascular factors. Either a stress test, ECG, then 2D echoes, and all these can be repeated as and when needed. Or preferably at least 3 monthly or 6 monthly, especially for those above 50 years with CV risk factors, and definitely for those with above 65 years of age. Then in radiological angstbond, tofacitinib and upadacitinib have a good efficacy. Next slide, please. Now we will go through the adverse effects also, and where we have to cautionary points about all these groups of drugs. So pancytopenia, neutropenia, liver function derangement with tumor necrosis factor inhibitors has to be has to be considered, and they should be every 3 to 6 monthly. They should be monitored. Next slide, please. So tumor necrosis factors, demyelination, PML, progressive multifocal leukoencephalopathy, demyelination, multiple sclerosis, or even peripheral neuropathy, or even lupus-like syndrome also can occur with TNF. These are rare adverse effects, but should be watched out for. And in any of these three conditions, the drug should be immediately stopped. So, and then previous history of malignancy, it should be avoided. TNF inhibitors should be avoided. And in case of uveitis, while using TNF inhibitors, you switch the drug to some other TNF inhibitor and take a call whether it is useful. Then TNF inhibitors uh, are the major side effect is infections, and infections with tuberculosis or any other opportunistic infections. But tuberculosis is and granulomatous infections are, one has to literally be on the alert all the while. Next slide. Next slide. So, these were the drugs. So after NSAIDs, how do you start? When do you start biological therapies for patients? This is also a recommendation by EULAR. Your diagnosis should be confirmed. CRP and should be high. MRI and evidence of sacroiliitis. Okay. And failure of standard therapy like non-pharmacological and NSAIDs. Then you think of here he's given 2 NSAIDs over 4 at full doses for over 4 weeks. Consider biologicals. Patients with predominant peripheral manifestations, 1 local injection of steroid can be tried, and if not improving, you go ahead with biologicals. And high disease activities, when the DAS score, BASRA is more than 2.1, you do consider positive rheumatology. And when the treating physician also feels that the disease activity is high in spite of NSAIDs, then go for it. Next slide. Then these are all, how do you assess, how do you know whether it is the disease is active? These are some of the factors: CRP, spinal mobility, function. Go to the next slide, please. So, next slide. Okay, can you go to the previous slide? So, Bath ankylosing spondylitis disease activity score, a score above it is scored on 10. Here, I don't know, it hasn't come. But in any case, the CRP, then functional, the mobility of the patient, then all these factors are taken into consideration. It's available on online also, and ESR, CRP.
Sample काढले का शंकरचं?
Yeah.
How sister?
Go to the next.
शंकरचं काढले sample? पाठवलं?
Functional BASFI is the functional index. Anything above 6/10 is a high functional limitation. This can happen in active disease or severe ankylosis. This is all daily activity is examined and is scored on a scale of 10. Next one. So, association between clinical disease activity and MRI inflammation is modest, but in spite of it, we need to look at all of them. Look at these BASDI and these scores, and the radiographs of the spine once in 2 years is, if at all required. If it is not, if you don't, it can be decided by the physician, treating physician. If it is absolutely necessary, or a fracture or any progression of disease is suspected, probably then an MRI or a change of treatment is required. Then it is to be considered. Next treatment. Next more than 50% improvement in BASDAI score to be considered. Shashank? Shall I share my screen? Okay. No, so I'll go ahead one second. So we're almost through with it. So before we start any biological, the baseline investigations would include CBC, liver function test and renal function test, and a chest X-ray, hepatitis B, C, HIV, and should be done. Essentially, to rule out any infection or latent tuberculosis can be tested for with both IGRA and Mantoux test, and chest X-ray and sonography also of the abdomen. And in case of a suspicion, HRCT test can be done for to rule out tuberculosis. Next slide. Patients. So HCV and hepatitis B virus, core antigens have to be checked for in case of suspicion, strong suspicion, or if the patient is already reporting. And we need to look for liver function tests recurrently every 1 to 3 monthly. And in case of reactivation, therapy should be instituted for both HCV. Next slide. So TNF inhibitors are safe in HCV, and in HIV patients, they can be given along with retroviral, antiretroviral therapies. Next. So tuberculosis, TNF is essential, like for all. It's a primary host defense against mycobacterium and granulomatous pathogens. But when we give TNF blockers, there is a higher risk of tuberculosis reactivation, especially with infliximab, than with etanercept. So we can choose, in case of suspicion, we can always choose a receptor blocker to a monoclonal antibody. And in case of latent tuberculosis where IGRA or Mantoux is positive, then we would probably give we have to give at least 1 month course of anti-COX-3 therapy and then institute TNF blockade. And in case of active tuberculosis, a 3-month course is required, and after that, a TNF blockade or any biologicals can be given. Next, please. So, can go to the next. So this is also therapy, whatever I've just spoken in a flow chart. Next one. So special situations like ankylosing spondylitis with uveitis, etanercept is not preferred, and adalimumab or infliximab work very well rather than etanercept or secukinumab. Next. So in case of IBD, monoclonal antibody against TNF is preferred, and for psoriatic uh, arthritis, IL-17 inhibition is preferred. And IL-17 inhibition is contraindicated in IBD. And next slide, please. So vaccination, a word about vaccination. Pneumococcal influenza vaccine annually should be given, pneumococcal vaccination, and uh, human papilloma virus and vaccination also, vaccination to be given to all patients. And live attenuated vaccine should be avoided, and any vaccination preferably to be given at least 1 month before, 1 month or 2 months before starting biological agents. Next one. So that's it. Anything I may have missed something. So is that okay, Shashank?
Yeah, absolutely, madam. Absolutely. Thank you very much for that detailed session. Uh, you can put in your queries in the chat box now. Maybe just for the benefit of everybody, I'll just try and summarize. Whenever we see seronegative spondyloarthritis or ankylosing, we first of all look at whether it is purely axial or peripheral or axial plus peripheral. Ankylosing would be predominantly axial. Axial means it would be involvement of the spine, sacroiliac joints, hip, shoulder. Peripheral would mean involvement of the peripheral joints like knee, ankle, foot, hand joints. And along with that, we would have a look at the peripheral, the additional structures that can be additional domains that can be involved, like dactylitis, enthesitis, and uveitis. This will determine what agents we use. If we talk about purely axial disease, ankylosing spondylitis is predominantly axial disease. So in that case, the first line of treatment would be NSAIDs, at least 2 NSAIDs, at least for 4 weeks. If the disease activity is persistent, then we would move on to the next agent. Next agent, technically disease modifying agents. As far as sulfasalazine is concerned, sulfasalazine is being used for years together. But there are two schools of thought. There is, despite it being in practice for so many years, we don't have sufficient evidence. In fact, there are quite a few rheumatologists. There is a school of thought that probably sulfasalazine is just not useful or effective in ankylosing spondylitis. So some rheumatologists would give sulfasalazine at this stage. Some would not go. So after NSAIDs, either sulfasalazine, or you straight away think in terms of either biologics or tofacitinib. Biologics, we have TNF alpha blockers, we have interleukin 17 blockers, and as far as the JAK inhibitors are concerned, presently tofacitinib is something that is approved for ankylosing spondylitis in India, in US, and the European Union. Among biologics, we have TNF alpha blockers, interleukin 17 blockers. If we have to choose between the two, there are not many head-to-head studies to choose between the two. If uveitis is there, TNF alpha, particular monoclonal antibodies definitely work better. In IBD, again, TNF is the agent of choice among biologics. The JAK inhibitors are the newer agents. JAK inhibitors are oral agents. Tofacitinib is something that madam just spoke about. So the biggest advantage is IV versus oral, and the cost again is it's they are much more economical as compared to TNF blockers. Apart from the common side effects of more prone or predisposition to infections, the additional side effects that we have to be careful about as far as JAK inhibitors are concerned are they can potentially increase the lipids, and they are known to cause increased thrombovascular events. So somebody with comorbidities, elderly patients, diabetic, hypertensive, hyperlipidemia, they may not be the best choice to use. Then TNF alpha blockers would be a better choice. When it comes to psoriasis, psoriasis falls in the psoriatic arthritis falls in the same group as the seronegative spondyloarthritis group. When it comes to that, secukinumab, if the skin involvement is predominant. So if when we look at psoriatic arthritis, we look at how apart from the arthritis, how active is the skin component. If the skin component, the psoriasis component is quite active, then secukinumab has is a better agent as compared to TNF alpha blockers, because secukinumab takes care of the psoriasis component quite significantly as compared to TNF alpha blockers. So this is how we choose between the two. Before we start any biologic or JAK inhibitors, along with routine test, we always look for latent tuberculosis. TNF alpha is involved in the granulomas of tuberculosis. So latent TB, once we give TNF alpha blockers, the granulomas can open and latent TB can become active. So we always look for latent tuberculosis in with the help of TB Gold, the IGRA test, and Mantoux test. If any of these is positive, we need to treat latent TB before actually starting a TNF alpha blocker. The same holds true for JAK inhibitors as well. JAK inhibitors, in addition, we also look for lipid levels. If the lipid levels are high, we obviously need to treat them as well. And believe me, this has changed the treatment scenario. Both these agents, biologics as well as the now available JAK inhibitors, have changed the treatment scenario of ankylosing spondylitis in a big way in recent times. Dr. Gauri Pathak, a question for you, madam. What should be the duration of JAK inhibitors? 5 milligrams BD preferred or 11 milligram OD?
Pardon?
What should be the duration of JAK inhibitors? 5 milligram BD preferred or 11 mg OD?
I think it's basically a convenience for the patient, and it is both can be tried.
Yeah, and currently there is not much data on the duration of JAK inhibitors. So that's something that probably data will tell us in the future.
As well as there's increased risk of cardiovascular and malignancy risk beyond 5 years. So I think I would personally give it for a considerable time for a remission, and once remission is achieved, maybe try something else. Put introduce something else so that patient does not enter that risk zone.
Yeah, starting from where I had left, you can keep putting your questions, posting your questions here. We would take them up.
And
Starting from,
Shashank, thanks
yeah,
for the comprehensive summing up everything. It was really good.
thank you. Thank you. Coming to the peripheral component, we just talked about the axial part. If somebody has axial plus peripheral or predominantly peripheral component, then we would have more options. One, NSAID is definitely yes. Second would be if a single joint is involved, then intra-articular steroids. If multiple joints are involved, DMARDs definitely do have a role here. Both sulfasalazine, methotrexate, and even leflunomide can be used in this scenario. If things don't work, then we move on to biologics or tofacitinib. When it comes to the additional domains that we looked at, dactylitis, NSAIDs definitely do work. There is not much role of methotrexate, sulfasalazine going by evidence. So if there is persistent dactylitis, we would escalate to biologics. If there is persistent enthesitis, again NSAIDs. If NSAIDs don't work, methotrexate, sulfasalazine doesn't have a significant role going by evidence, then we would again escalate to biologics. Uveitis, methotrexate definitely has a role to play. If things don't settle with methotrexate with a short course of steroid, biologics, among biologics, monoclonal antibodies would be preferred. Anything else that you would like to add, madam?
No, it's perfectly fine.
Uh,
Practically, I think beyond uh, the conventional DMARDs for peripheral arthritis, before we go into biologic agents, we should be aware completely of the risk profile, and it would be advisable to take, do it very absolute carefully. Any increase, jumping to biologics, because nowadays anybody gives the oral JAK inhibitors to tofacitinib, which is not really advisable, because in the long run, tofacitinib, though it is a good molecule, it has shown to have malignancy and cardiovascular effects, and even thromboembolic effects. Therefore, we need to be really, really careful, and not just give it randomly and indiscriminately.
Absolutely, madam. In that case, then if we don't have any more questions, we'll close the session for the day. Do join us. There'll be the next session will be 2 weeks from now, and I would post the details in the group 4-5 days in advance. Thank you, Dr. Mamatha. Thank you
Thank
all.
you.
Let us meet again for the next session. Thank you.
Thank you.